My name is Dr. and today's lecture is the start of a new system, the gastrointestinal system. The first topic will be the anterior abdominal wall and the esophagus. We'll start with the anatomy of the anterior abdominal wall. The anterior abdominal wall extends from the xiphoid process and the lower 6 costal cartilages to the anterior aspect of the pelvic bones. It's composed of several layers. We will get into the details of these layers later. The skin, the superficial fascia, subcutaneous fat, muscles, transversalis fascia, extraperitoneal fat, and peritoneum. These are the components, again, the skin, which we can see is here, followed by superficial fascia, which consists of 2 layers, a fatty layer called camper fascia, and a membranous layer called scarpa fascia. And then we have 3 muscle layers from external to internal, external oblique, internal oblique, and transversus abdominis muscle, followed by a membranous layer of deep fascia, then extraperitoneal fat and peritoneum. صوتي واضح؟
واضح بابا رواس.
We'll start with the superficial fascia. It consists of 2 layers, as we said, camper's fascia and scarpa's fascia. In general, it's a single fat-containing layer in the superior and central anterior abdomen, which then divides into 2 layers inferiorly, between which run vessels, nerves, and lymphatics. The superficial layer is fatty layer. It contains areolar tissue with variable amounts of fat. It passes over the inguinal ligament and is continuous with the superficial fascia of the thigh. The deeper layer, that's also part of the superficial fascia, is scarpa's fascia. This is a membranous layer containing elastic fibers connected to the aponeurosis of the external oblique muscle laterally, to the linea alba and symphysis pubis medially, continuous with the superficial layer over the trunk superiorly. It passes over the inguinal ligament infralaterally to fuse with the underlying fascia of the thigh, known as fascia lata, and it forms a superficial perineal fascia, Colles fascia, inframedially by passing over the penis and scrotum in males and into the labia majora in females. هنا هاي الصورة توضح superficial fascia. It consists of 2 layers, a fatty layer, camper's fascia, and under it is a membranous layer, scarpa's fascia. Scarpa's fascia is continuous as Colles fascia in the perineal area. After the superficial fascia, we have 3 muscle layers. The important ones are 3. The first is the external oblique muscle, which arises on the anterior surface of the lower ribs and is inserted into the linea alba, pubic crest, inguinal ligament, and iliac crest. The aponeurosis of the external oblique muscle is included in the formation of the inguinal ligament, the thickened free edge of the external oblique aponeurosis between the anterior superior iliac spine and the pubic tubercle, 12 to 14 centimeters in adults. It's continuous with the fascia lata over the thigh. The medial part of it forms the lacunar ligament, which is the medial margin of the femoral ring. The superficial inguinal ring is a hiatus in the external oblique aponeurosis lying supralaterally to the pubic crest. It carries the spermatic cord in males or the round ligament in females and the ilioinguinal nerve. This is the inguinal ligament extending from the pubic tubercle to the anterior superior iliac spine. It's the thickened free edge of the external oblique aponeurosis. The internal oblique aponeurosis arises from the lumbar fascia, the iliac crest, and the lateral 2/3 of the inguinal ligament, and is inserted into the linea alba and the costal margin. Its aponeurosis splits into upper 2/3 to form part of the anterior and posterior layers of the rectus sheath, but below the umbilicus, it passes anterior to the rectus sheath. The transversus abdominis muscle arises from the lower ribs, interdigitating with the diaphragm, the lumbar fascia, the iliac crest, and the lateral half of the inguinal ligament, and is inserted into the linea alba. Its aponeurosis consists of the lower fibers traveling inframedially with the internal oblique to insert into the pubis, forming the conjoint tendon. The remaining fibers travel medially to contribute to the linea alba, But above the umbilicus, it passes behind the rectus abdominis, and below it, it passes in front of the muscle. عندنا بعد the rectus abdominis muscle. It's a thick ribbon of muscle on either side of the midline from the costal cartilages to the pubic crest. It has 3 to 4 tendinous intersections at intervals along its length, which adhere to the anterior rectus sheath. The smallest of these muscles is the pyramidalis muscle. It's a small triangular muscle anterior to the rectus abdominis and contained within the rectus sheath. It originates from the pubic symphysis and pubic crest and inserts into the linea alba. This is a summary of the muscles of the anterior abdominal wall. We have the rectus abdominis muscle over here in the front, followed by the pyramidalis muscle, which is found deep to it. We have the 3 muscles on the side, which are the external oblique, internal oblique, and the transversus abdominis muscle. The rectus sheath is a structure that encloses the rectus abdominis and pyramidalis muscles and forms an important component of the anterior abdominal wall. It's composed of the aponeuroses of the transversus abdominis, external oblique, and internal oblique muscles, which form anterior and posterior layers of the sheath that fuse laterally at the linea semilunaris and in the midline at the linea alba. عندنا line اسمه الarcuate line. The rectus sheath has different components in front of, above, and below this line. The line is a curved line found posteriorly to the rectus abdominis muscle bilaterally. It's also known as a semicircular line of Douglas. It's usually located a third of the distance from the pubic crest to the umbilicus. Anteriorly, the rectus sheath will be composed of the external oblique aponeurosis and the anterior lamina of the internal oblique aponeurosis. But the posterior layer will be composed of the transversus abdominis aponeurosis and the posterior lamina of the internal oblique aponeurosis. This is above the arcuate line. But below the arcuate line, only the anterior layer of the rectus sheath is present. It's composed of the aponeurosis of these 3 muscles, only covered by transversalis fascia posteriorly. This image shows the rectus sheath above and below the arcuate line. This is a clear image. It shows that the internal oblique aponeurosis splits to become a layer in front of and behind the rectus sheath, while below the arcuate line, all 3 muscles will pass in front. The aponeurosis of all 3 muscles will pass anteriorly. Next, we have the transversalis fascia, which is the deep fascia of the anterior abdominal wall. It's a membranous layer consisting of thin areolar membrane lying between the transversus abdominis and the extraperitoneal fat. It's continuous superiorly with the inferior diaphragmatic fascia and inferiorly with the iliac and pelvic fascia. Posteriorly, it fuses with the thoracolumbar fascia. It's pierced at the deep inguinal ring by the spermatic cord in males and the round ligament in females. After this, we have a layer of fat that lies between the peritoneum and inner surface of the transversalis fascia. This shows the components of the anterior abdominal wall. We have the skin, followed by superficial fascia that consists of 2 layers, a fatty layer and a membranous layer, followed by the 3 layers of muscle. Then we have the deep fascia, fat, and parietal peritoneum. There's a topic called umbilical ligaments. It's part of the anterior abdominal wall. It's included with it because clinically it has a significance in radiological anatomy. The first one is the median umbilical ligament. It's the fibrous remnant of the urachus, which runs from the fundus of the bladder on the deep surface of the anterior abdominal wall to the umbilicus as a cord of variable thickness. It's covered by a fold of peritoneum. We have also the medial and lateral umbilical ligaments. The medial umbilical ligaments are the fibrous remnants of the obliterated umbilical arteries, and they run from the internal iliac artery to the umbilicus on the deep surface of the anterior abdominal wall. These are also covered by a fold of peritoneum. And the lateral umbilical ligament is sometimes used to describe the inferior epigastric artery and its covering fold of peritoneum as it passes supromedially from the external iliac artery to enter the rectus sheath posteriorly. This image shows the median umbilical ligament in the midline, followed by the medial umbilical ligaments on either side, and the lateral umbilical ligaments contain the inferior epigastric vessels. Any questions till now?
اكو سؤال؟ ماكو، تفضل.
Plain films of the abdomen. We'll start now with the radiological features of the anterior abdominal wall. Regarding plain films, the muscle layers of the anterior abdominal wall are outlined, especially in obese, between the subcutaneous fat line and properitoneal fat line. Clearly seen fat lines indicate the lack of edema in these areas, although in 18% of normal, the properitoneal line is absent. This is a plain film abdomen. You can see here, it's not very clear, but we can see the internal oblique muscle, but most importantly is here where we can see the properitoneal fat line. However, we said in 18% it may be absent. Its presence indicates the absence of edema. Here we'll talk about the radiological signs of pneumoperitoneum, and these are related to the umbilical ligaments that we mentioned earlier. The first is the Eureka sign, which is a radiological sign of pneumoperitoneum. It represents the outline of the median umbilical ligament with free abdominal gas in a supine patient as seen on plain abdominal film. Right here. We have the inverted V sign. This represents free gas outlining the lateral umbilical ligaments on a supine abdominal film. This is the inverted V sign. Ultrasound is useful in evaluating focal masses in the anterior abdominal wall, but it does not demonstrate the anatomical relations as well as CT or MRI. CT and MRI of the abdomen show excellent anatomical detail of the anterior abdominal wall in the axial plane. MRI has superior soft tissue contrast resolution, but images can be degraded by respiratory artifact. The muscle layers of the anterior abdominal wall can be seen in cross-section. 3 muscles can be seen anterolaterally. The external oblique is the outermost, followed by the internal oblique, and the transversus abdominis is the deepest. The rectus muscle and its rectus sheath can be seen in the anterior paramedian position, superficial to the other muscles. This is the axial CT showing the muscles of the anterior abdominal wall. We have here the linea semilunaris and the linea alba. This is the rectus abdominis muscle. This is the external oblique, internal oblique, and the transversus abdominis muscle. These are the muscles around the spine, the quadratus lumborum and the ectosuit spiny muscle. Another image, the external oblique, internal oblique, and the transversus abdominis muscles. These are axial and coronal MRIs, showing also the linea alba, the linea semilunaris, and the muscles of the anterior abdominal wall. Any questions regarding the anterior abdominal wall?
اكو احد عنده سؤال بابا؟ شرحت المسلز الفيشيا سوبرفيشال والديب فيشيا. اكو احد عنده اضافه او سؤال؟
Our next topic is the esophagus. It's the first structure we are going to explain in the gastrointestinal system. The anatomy of it, it's a long muscular tube measuring approximately 25 centimeters. It extends from the level of the 6th cervical vertebra, which is the level of the lower border of the cricoid cartilage. It passes through the neck, the posterior mediastinum, and then it will veer anteriorly within the thorax before entering the abdomen through the diaphragmatic hiatus at T10. Its short course within the abdomen is retroperitoneal and forms the gastroesophageal junction as it ends at the cardia of the stomach at T11. This shows the esophagus starting from the lower border of the cricoid cartilage. Starting from the lower border of the cricoid cartilage, passing through the neck, the posterior mediastinum, and then entering the abdomen at T10 and ending at T11. The relations of the esophagus within the chest. Anteriorly, as it descends, it passes behind the trachea, the left main bronchus, the left atrium, and the left ventricle. Posteriorly, the thoracic duct, the vertebra, the esophagus vein, the right posterior intercostal arteries, which arise from the descending aorta directly. Laterally, on the left, it's in contact with the origin of the left subclavian artery, arch of the aorta, left lung, and descending aorta. On the right, the esophagus vein lies behind and to the right, crossing it at T4 where it terminates. Above this level, it abuts the right lung. The CT, midline sagittal CT, shows the esophagus and the chest behind the posterior mediastinum, behind the left atrium, and behind the left main bronchus. Arterial supply and venous drainage of the esophagus. The upper third, it's divided into 3/3 to make it easier also. The upper third is the inferior thyroid artery and is drained into the inferior thyroid vein. The middle third is supplied directly from the descending aorta by esophageal branches, and it drains into the esophagus vein. The distal third is supplied by branches from the left gastric artery, and it drains into the esophageal branch of the left gastric vein, which drains into the portal vein. This is the upper third. It's supplied by branches of the inferior thyroid. And then the middle third supply esophageal branches from the aorta. And then the lower third is supplied by the left gastric artery. Nerve supply is divided into 2 divisions. The upper esophagus is supplied by branches of the recurrent laryngeal nerve. The lower esophagus is supplied by the esophageal plexus, which surrounds the lower esophagus, and it's made up of the parasympathetic fibers of the vagus nerve and vasomotor sympathetic fibers from the upper 4 to 6 thoracic spinal segments. This is the nerve supply. Superiorly, the upper half is supplied by the recurrent laryngeal nerve, and the lower half by the esophageal plexus that contains sympathetic and parasympathetic fibers. The lymphatic drainage of the esophagus. Paraesophageal lymphatic plexus drains the esophagus superiorly into the posterior mediastinal lymph nodes, and then into the supraclavicular node. Inferiorly to the left gastric, gastrohepatic, and celiac lymph nodes. This lymphatic drainage explains the pathway of spread of esophageal tumors via lymphatics. Any questions regarding the anatomy of the esophagus?
اكو احد عنده بابا question؟ قسمت الابر والميدل واللور ثيرد، وكل واحد الارتريال سبلاي همينه مالته والريليشنز. اكو احد عنده سؤال؟ لو نروح على الراديولوجي. تفضل يا رواسي بابا.
Radiology of the esophagus. First, we'll start with the plain chest radiograph. The esophagus is difficult to see unless it's dilated and fluid-filled. Below the level of T4 or the right hilum, the zygoesophageal line may be seen, where the esophagus vein and the esophagus abut the right lung. However, above T4, where the esophagus abuts the left lung, we can see the pleuroesophageal line. This is the zygoesophageal line or recess. On endoscopic ultrasound, the esophagus has 5 layers. These layers alternate between hyperechoic and hypoechoic bands. The superficial mucosa is hyperechoic, followed by the deep mucosa or the lamina propria, which is hypoechoic. The submucosa is hyper, the muscularis propria is hypoechoic, and the adventitia is hyperechoic. These layers are poorly seen on CT. However, MRI is showing some promise with newer improved sequences. For endoscopic ultrasound, we use it in local staging of esophageal tumors because it shows the layers in detail. This is an image of the endoscopic ultrasound showing the esophageal layers as alternating bands of hyper and hypoechoic regions. The main radiological method of assessing the esophagus is the barium swallow technique, where the esophagus is outlined by barium. Gas is usually swallowed in addition to give a double contrast examination and to distend the esophagus. Sometimes a paralyzing agent such as buscopan is used to stop esophageal contractions, allowing a better appreciation of anatomy. The esophageal mucosa is arranged in longitudinal folds that are best seen when the esophagus is not distended. These measure approximately 3 millimeters in width. The thicker folds of the stomach are seen distally, indicating the esophageogastric junction. In normal people, these may rise into the thorax unswallowed. In a frontal view, in the lateral view, right anterior oblique, 3 views. The frontal view, the oropharynx may be examined, in which the piriform fossae are outlined by barium, and the epiglottis and the base of the tongue will show as filling defects in the midline. The cervical esophagus is seen to curve slightly to the left. On the frontal view, the esophagus has a left-sided indentation from the aortic arch. The left main bronchus also makes an impression on its left side, and it makes a linear impression as it indents the anterior wall of the esophagus. This is a frontal view showing the piriform fossae, and it also shows the epiglottis as a filling defect in the upper part of the barium swallow. And this is the cervical esophagus. On the lateral view, the tongue base and epiglottis are seen from the side, with the valleculae between a posterior indentation caused by the contraction of the cricopharyngeus muscle to initiate deglutition, indicating the commencement of the esophagus proper. Just below this, on the anterior wall of the esophagus, a small impression may be made by a submucosal plexus of veins. The cervical esophagus is seen to lie on the anterior surface of the vertebral bodies of the cervical spine. This is the lateral view of the esophagus. It shows first the cricoid impression indentation, indicating the beginning of the esophagus. And also there's an indentation from the cricoid venous plexus. And this is the cervical esophagus. Lateral view of the barium swallow. In the chest, the esophagus is best demonstrated with the subject rotated slightly off lateral in the right anterior oblique position. In this position, 3 major impressions are seen anteriorly. They are caused by the aortic arch, the left main bronchus, and the left heart, mainly the left atrium from above down. In this position, the esophagus can be seen to curve anteriorly in its distal part to enter the stomach. This is the right anterior oblique. This is the best position to see these 3 indentations: the aortic arch, the left main bronchus, and the impression of the left atrium. The lower end of the esophagus has a fusiform dilatation just above the esophageogastric junction. This is called the esophageal vestibule. On barium examination, the upper part of the vestibule is defined by a transiently contractile ring known as the A ring, and the lower limit of the vestibule is defined by another ring known as the B ring, or transverse mucosal fold. This is the lower end of the esophagus at the esophageogastric junction. It shows the vestibule, bounded by the upper limit of which is the A ring and the B ring, and then the gastroesophageal junction leading to the stomach. Cross-sectional imaging. The esophagus may also be imaged by CT and MRI. On cross-section, its relationship to the other structures of the thorax is appreciated. Its visualization is improved if it contains air. When collapsed, it is seen as a narrow, thin-walled structure in the posterior mediastinum. Appreciation of the areas in which air-containing lung is adjacent to the esophagus provides an understanding of the mediastinal lines seen on the frontal chest radiograph. This is a CT showing the esophagus. Here it contains a small amount of air. And this also is a midline sagittal and coronal reformatted image showing the esophagus beginning at the cricopharyngeus and ending at the gastroesophageal junction. This image shows the measurements that are used in endoscopic ultrasound. It starts with the upper incisors at 0 centimeters. and that leads to the upper esophagus at 15 centimeters. And then you can continue down up to 40 centimeters from the upper incisors to reach the lower end of the esophagus. Any questions regarding the esophagus?
اكو احد عنده سؤال قبل ما نروح على الكويز؟ تفضل، اكو سؤال منو؟ يلا دكتورة رواسي ماكو سؤال؟
اوكي
نروح على
تمام.
نبدي بآيات حسين.
نعم دكتور.
شنو هذا الإكزام بابا؟ دكتور آيات تسمعيني؟
نعم دكتور اسمعني. باريم دكتور، باريم.
هذا فرونتال يعني؟
anterior posterior دكتور.
متأكدة؟ يعني قصدي فرونتال؟
اي امامي، اي دكتور فرونتال.
لا هذا مو فرونتال. عادة احنا الأسوفيغاس بالفرونتال مثل ما قلت لك، بس الأبر ثيرد يفيدنا نشوف السيرفايكال أسوفيغاس، بس الباقي عادة نسويه
رايت انتيريور
lateral oblique. هذا lateral oblique بدي. اوكي
نعم.
آيات؟
نعم دكتور.
هسه قولي لنا اي شنو هذه؟
esophageal impression from aortic knuckle.
اي يعني خلينا نقول first indentation of the aortic arch او aortic knuckle اللي هو normal impression. هذا نشوف. اوكي شكرا.
نعم.
لينا حسن.
نعم أستاذ.
بي
esophageal impression from left main bronchus.
left main bronchus impression on the esophagus. on the anterior طبعا aspect of the esophagus. نروح على دكتور حيدر.
نعم عمي.
حيدر عباس.
نعم عمي. السي هو هنا الهيمي دايفرام يكون الليفت سايد.
ليفت لا رايت؟
نعم هذا الليفت.
ليفت ليش؟
لان عمي هو يعني يصير الاسوفيجاس يعني هذا الاتجاه الليفت موجود، وبالاورتيك نكل اللي يصير بجهه اليسار الفوق الامبريشن.
لا احنا ما يخالف، احنا عندنا لاند مارك نقول هذا الليفت هيمي دايفرام او الرايت. هنا شنو اللاند مارك؟
من نشوفه الجو بالفيلم اللي موجود الغاز اللي هو الغاز فانداس يعني.
بالضبط هاي الجاستريك اير بابل.
الاير بابل فانداس
وذا ستومك.
منو فاتح السبيكر مالته؟
هونر هذا الصوت مال هونر.
دكتور هونر شد السبيكر الله يخليك.
من نشوفه بالفرونتال فيو نشوف الغاز اللي موجود مال ستومك الجاستريك فانداس اللي يكون بالليفت سايد. فالفوق الدايفرام يكون ليفت دايفرام.
اوكي عاشت ايدك. دي سولين.
نعم دكتور، هاي lower part of the esophagus.
او اللور ثيرد اوف ذا اسوفيجاس. تتوقعين وصلنا هذه الفستيبيول لو بعد احنا؟ سولين تسمعيني؟
نعم دكتور، بس عفوا can you repeat the question؟
تتوقعين هذا الدي ليفل وصلنا الفستيبيول مال الاسوفيجاس لو بعد؟
لا بعد دكتور.
بعد اوكي. دكتور حسن محمد باقر.
نعم أستاذ. الإي هذا gas within the gastric fundus.
Gas within the gastric fundus. اوكي. استاذ محمد تفضل. استاذ محمد.
شكرا استاذ رعد. هيفاء اسعد.
نعم استاذ.
اي
internal oblique muscle. الرايت الليفت left internal oblique muscle transverse.
ما هي فا.
سوري والله خربطت بيهم.
يلا هاوري بي.
نعم أستاذ. بي هو هذا right internal oblique muscle.
نعم. زين. مينا مازن سي.
نعم دكتور. هذا الابينوروسيس of left external oblique muscle.
نعم. نور فاضل دي.
نعم دكتور. right rectus abdominis muscle.
رايت ركتس ابدومينال. وعندنا الاي موج فائق اي.
نعم أستاذ، هذه اللينيا ألبا. تسمعني أستاذ؟
اي
نعم.
عشتي شكرا دكتورة